Hello again. I hope you've enjoyed today's content so far. Please do keep all your thoughtful questions coming, as they provide great insight into benefits and challenges. Protecting the mental health of NHS staff is increasingly seen as a huge contributing factor to NHS workforce sustainability and efficiency. However, there's still a long way to go. In the latest NHS staff survey, 37% of respondents said that they find their work emotionally exhausting. 32% said they didn't have enough energy for their family and friends, and 40% said their work frustrates them. These numbers have a direct effect on recruitment and retention, as well as the efficiency of staff whilst they're on shift, which could in turn affect patient experience and safety. NHS trusts are exploring different ways that they can protect their staff from stress and burnout. And in this panel, we'll be discussing what currently is going on in that space and what improvements could be made to help the mental well-being of our staff members. So to share some of their experiences and learnings, I'm delighted to say that I'm joined by Aileen Jackson, Head of Mental Health at the Health Innovation Network, Joan, Bowen, Head of Staff and Wellbeing for Guy's and St Thomas's NHS Foundation, Emma Weekly, Consultant in Intensive Care and Anaesthesia at Bolton NHS Foundation Trust, and Andrew Molodinsky, Consultant Mental Health Lead for the British Medical Association. So I put my glasses on to check everybody's there. Everybody's made it onto the virtual stage. Really nice to see you all for our final panel discussion of the day. Aileen, I thought if it's okay with you, we'll start with you. According to the latest NHS survey, many people feel tired and frustrated and emotionally drained. What effect does that have on the pressing issue of recruitment and also retention?
So as an academic health science network, we don't directly work in NHS trusts. We support NHS trusts to adopt evidence innovation. So what we will find is when we work with the trusts that that can really have an impact on who's available to actually step up to work with us and to implement an innovation, because they take time. They take time, they take resources. What we do know is that when people do work with us, that does mean that they actually get some benefits, because everything we do has to improve patient outcomes, and that's huge positive benefit for the staff, because that helps them to feel that they're actually achieving something alongside their obviously the very busy day jobs, and that they're looking to the future at how they can improve efficiencies, how they can actually benefit patients, save time, and hopefully get earlier diagnosis and earlier treatment.
Have you got any examples, Aileen, just to give us an idea of how you can help and support?
So yeah, one of our national programmes was supporting children and young people's services, so both paediatric and mental health services, improve the diagnosis of children with ADHD. And so we took a evidenced innovation, something called QB test, which had evidence that it did save clinicians time, reduce number of appointments that's needed. It's very intensive diagnosing people, young people, particularly with ADHD. You need a lot of reports and lots of observations. And we've now rolled that programme out nationally, and we have got an average of 11.5% reduction in clinical appointments needed. So that's an average, and so some are much higher and obviously some lower. But what that means is that frees up clinicians' time to either see more patients, there's huge waiting lists. It frees up, more importantly, it frees up the young person and their family to get on with their lives and have a diagnosis. And so many of our programs, all of our programs, need to evidence that we can achieve those outcomes. So that's just one example.
Yeah, such a good example. Thank you for sharing that with us. Joan, you're at Guy's and St Thomas's, and just before you came onto the virtual stage, I was asking about the size, because I know it's a massive hospital, but it sounds like a small town, really, 25,000 members of staff. So it really is huge. What's currently, would you say, having the biggest negative impact on the staff and their mental health and their well-being where you are?
Certainly for the last meetings that I've been attending over the last weeks and months, we're seeing on the top of every agenda increasing amounts of aggression and violence towards our staff from patients and members of the public, whether that be face-to-face contact, and also affecting people doing our call centres, our call handling as well. And that's really having a significant impact on people feeling that they want to do their best and but not feeling equipped to deal with, and that's coming from lots of different angles. I think partly to do with frustrations from waiting lists and so on, and what patients are facing in terms of that. Also in terms of perhaps higher levels of mental distress, mental illness within our acute settings, and patients and our staff coming into contact, particularly our staff, our non-clinical staff, not feeling as equipped as they could be to deal with those situations. And then really the impact on them emotionally of how they feel afterwards, because we're all human and we all react and we all feel a certain way, even when we take the empathy and thinking about where that comes from with our patients and their families. That is happening more and more, and it's having a massive impact. And I think that alongside our staffing challenges, so we are, very tight teams, very tight. So even if we want to put the training and the time in to support people, or to do reflective practice, or to support people in terms of de-escalation training and development, people just cannot be released to attend that. So yeah.
Yeah, well, I was going to say, Joan, particularly, with the aggression that they're facing, how do you, what can you offer? But I suppose you've slightly touched on that there. If there's training you could offer, but your teams presumably are too stretched and too pressed to sometimes take up what you can offer. Is that fair to say that? Is that what happened?
Yeah, that's fair to say. I think we're very fortunate here in that our charity supports us significantly with our health and wellbeing programme, showing we care about you. And part of that support has been a massive increase in our psychological and spiritual care support for staff. And that means that any member of staff can self-refer into our staff wellbeing psychologist team. Also, we have multi-faith chaplaincy to support our staff as well, and that's been massively important on, I suppose, the sharp end of where patients need it, but where we want to provide a stepped approach, and we want to be able to provide staff with skills and tools and reflection time, just so that they can put those things into place. Perhaps they don't need the sharp end of expertise and expert support. That's where we're really struggling, and people are signing up and wanting to come to these things, and then last minute cancellations in DNA because they've been pulled back on shift, or they're just short staffed that day and can't attend.
Gosh, that's incredible. I mean, Emma, you're wellbeing lead for your department, and I know you've supported people through the pandemic, through strikes, through staff shortages, etc. Give us a flavour of what you're seeing with your teams.
So obviously it all came to light with the pandemic, because I work in critical care, and we were very much aware that staff were starting to struggle because of the pressures on critical care during the pandemic. We also recognise, as already been said, that people couldn't take time out to go to, sessions or courses or whatever it happened to be. So we decided to go back to basics and just do the simple things like make sure people got breaks, and we started supplying breakfasts and supper clubs actually within the intensive care unit, so that people actually had food, drink and sat down, even if it was only for a short time. And we also made sure they had somewhere where they could chat to colleagues that was completely not about COVID and all those other things. And we found that the impact of that was significant, because people were able to be there as a team, but also get some time out during the busy working day. We also very luckily, because we have psychologists collected to critical care, and the psychologists are usually for the patients, but we found we didn't need it for the patients as much because they weren't being followed up in the same way. So the psychologists came onto the unit and did group sessions and single sessions with staff while they were at work as well, which again provided that support. And we were lucky enough also to get some money from Captain Tom's fund.
Wow.
So we made a sort of quiet restroom. So we had a bit of a noisy, chatty restroom and a quiet restroom where people could just take time out and sit in silence if they wanted to, without any chatter in the background. And people really liked that. So those are some of the things we did just to support people at work.
Andrew, let's bring you into the conversation. Thank you for being so patient there. As well as being mental health lead for the BMA, you're also a consultant psychiatrist. I was going to ask you what you thought of the major causes of burnout in healthcare staff, but I just wonder if you kind of want to react to things there that Joan's been saying and Emma's been saying. I mean, are these things coming as much of a surprise to you or not really, I'm guessing? Oh, let's just put, Andrew, sorry, let's just put your microphone up. Just there you go, Andrew. I think you're up now. Sorry.
Okay. Can you hear me okay?
We can now, thank you.
Thank you for inviting me, and it's fascinating to hear the different perspectives so far. I mean, I think, as previous people have said, COVID shone a light on things, didn't it? But this is not a new phenomenon, and interestingly, in healthcare, we've been very poor at trying to measure burnout and trying to ascertain the extent of the problem until I think the pandemic came along, and now there's been a huge explosion in both sort of research work looking at, you know, what causes burnout and impaired well-being and what the remedies might be, but also the extent of it. I mean, for me, I think the causes are many, aren't they? I mean, that's the standard answer to everything, of course, and also shifting over time. So, you know, we know that things like workload, you know, increasing expectations from patients and families, which is a good thing. People being able to get more information online, people being much more aware of their health and looking at prevention and optimizing their own well-being creates much higher standards for people working in the health service, which is a good thing, but does come with added pressures and expectations, and that can be difficult for any of us. I think particularly over recent years, we've seen, and our research has shown, that the increasing impact of things like moral injury. So, you know, amongst clinical staff in the National Health Service, particularly that feeling of an inability to do one's best for the person sat in front of you, that there may be treatments or treatment pathways which are the right thing to do in terms of that patient's condition, but for which there are either very long waits. You know, and in my realm, in mental health care, it's not uncommon for people to wait 1, 2, sadly, even 4 years for particular kinds of therapy, which is almost like saying it's not available, really. And similarly, there are long waits for some kinds of surgery. But I think increasingly over recent years, and be interested to hear what other panelists think, I think the effects of austerity and staff either having to use food banks or knowing colleagues and friends who are having to reach out for charity, despite having sort of got through the pandemic, is having a really monumental impact on staff well-being, and I think is one of the root causes for the sort of the wave of industrial action that we're seeing, which is not so much people saying we want more money, but people saying, look, we've had enough of this.
Yeah, Joan, you were nodding away there. Would you agree with Andrew there in terms of, you know, the austerity measures and
absolutely? I think everybody would find that, but I think when you think about people working within acute trusts and also community sites across, you know, one of the most expensive places to live and find accommodation, and then you layer on the austerity and the cost of living, the impact has been massive and multidimensional, and we've had to put in all sorts of I suppose emergency support, but also broader support in terms of things like money A&E sessions to help people to better manage. But the ultimate, the fundamental is there isn't enough, and people are turning up hungry and tired and concerned about the future. And I think when you layer that on to what are already difficult, challenging jobs, it's so hard for our staff, and it's not getting any better anytime soon.
No, it's really sobering as well when you describe it like that. Turning up hungry, that, you know, you kind of, when you say turn up hungry, you imagine countries like Africa, don't you, and developing countries, not in Britain. You know, what's going on if staff are turning up not, you know, being able to you know, feed themselves and their families well, because things are so tight, and you know that it really is a hugely worrying problem. Aileen, you know, as an NHS organisation which leads on innovation, how does the HIN look after the well-being of its own staff? Can you give us an insight into what you guys do to take care of the teams?
Yeah, so we have made it one of our strategic priorities to actually to make sure that what we call make a joyful organisation. So we have given responsibility to 2 or 3 people within our organisation to lead on well-being for staff, and so it's part of their job. So I think, you know, that's the starting point. It has to be part of someone's job. It has to be protected time, and that sounds like an absolute luxury on the front line, but I think that's the only way forward. And what we've done is also look to our own resources. So a lot of what we offer is run by our own staff, and again, they're given the time to do that. So particularly with amongst 25,000, you're going to find some really talented and creative people, and we're just an organisation of around about 80 or 90. And you know, so we have someone passionate about books, runs a book club. They're not necessarily in working hours, but it gives people joy actually to be able to have a chat with someone about the book that they've read. There's regular meditation sessions that people can just join online. We're lucky to have a yoga teacher who happens to be a member of staff, but sometimes it's just a guided walk, just a walk, rounding people up in the office and say, take a break, come on, I'm going to lead a walk. So it's just finding some very simple solutions, but also having it from the top. Our execs, we have an exec lead. Our medical director is our exec lead for wellbeing of staff. And I think that's really, really important, that it's driven from the top and it includes everybody, that everybody's, you know, it's accepted part of work that you will look after your wellbeing. When I meet with my staff, I say, what are you doing to look after your well-being? It's a regular question.
Yeah, really good answer. I'm guessing though, Emma, in your world in critical care, you know, those things that Aileen's, you know, involved in with her teams, that, you know, again, it's going to be boiling down to time, isn't it? When you're in critical care, perhaps you can't get away and have that guided walk, or you're exhausted at the end of the day to go to the yoga session or whatever. But I'm just wondering what systems are in place. How do you know when there's an issue with staff well-being? You know, because I would imagine not every member of staff will go to somebody to tell them.
No, it was one of the difficulties we had actually, because inevitably, if you ask somebody if they're okay, they just say, I'm fine, thanks. And you know, that's not always the right answer. Sometimes you can follow it up with, are you really? But it doesn't always work. So we did, I don't know whether anybody see it, but on any NHS employers, they have a colour chart, which is red if you're feeling exhausted. I think it's blue if you're okay, and yellow if you're feeling a bit run down. So what we did is we put counters at the front of critical care. And when you walked in, you picked up a counter and just put it in which colour you were feeling. And we had a huge number of people who were feeling almost burnt out. And that was better than asking people directly, because people could just come in, pick up a counter, drop it in a pot and not have to speak to anybody about how they were feeling. Because I just don't think people want to admit that they're not feeling great. We did actually do walks. Because we try and encourage people to take breaks, because we recognise that if you don't have breaks, then your standard of work goes down. So we're lucky enough to have big grounds. So we just used to go out for 10, 15 minutes, even if that's all it was, because just being outside makes you feel better, doesn't it? So we used to have little groups that just went out for a little bit and then had something with the breakfast or supper club, depending on the time of day it was. So the little things did make a difference.
I suppose, Andrew, I mean, this is the $6 million question, really. But, you know, how can we solve this issue of burnout, or at least how can we make a marked difference? Because there's so much going against us, isn't there, with staff shortages and the pressures that teams are under. And that report that I mentioned in the intro, I mean, it makes really difficult reading for me. So what can we do to try and, I mean, obviously we've heard some great things that individual organizations are doing, but what's the answer to burnout, across the board?
I think anyone who could give an answer to that question would be very wealthy indeed, and also hopefully very fulfilled. It's difficult, isn't it? And I was struck by some of the NHS data from their own data set that between March 20 and September 22, so the real height of the pandemic, that there were 15 million working days lost in the NHS to burnout, which was twice as much as was lost to COVID during the height of the pandemic. So it is a vast problem. I mean, there are things that can be done, and I think one of the most positive things for me over the last couple of years has been that there's been a real shift in the way that it's talked about as being, from being a problem particularly with the individual who is burnt out, that they're in some way, weak or not resilient or unable to sort of cope with a set of working conditions, and a much more realistic and honest approach, which reflects the evidence, which is that most of the causes of impaired well-being and burnout are the system and the workplace. And there are some fairly basic things that can be done, although it's easy to say them and much harder to do them when there are staff shortages. So people having manageable and meaningful job plans, people having regular supervision and mentorship, people having access to outdoor space, people having sort of administrative burdens that comes up frequently as a major problem, having that minimized as far as possible. All these things have decent evidence bases on their own and combined have a cumulative evidence base, but they're just nightmarishly difficult to achieve in a huge organization that is, if anything, sadly going in the wrong direction in terms of, staff recruitment and vacancies, and it's certainly going in the wrong direction in terms of burnout, because we see year on year with surveys that rates of people experiencing difficulties is going up with time, not down, sadly.
Absolutely. Well, I know that was a tough question, but very, very good and thoughtful reply there. I know we can't solve it overnight, that's for sure. Joan, I'm just wondering, you've got this sort of 25,000 staff members that you're sort of trying to look after. Are there any staff groups in particular which perhaps you struggle to engage with in terms of, mental health and wellbeing initiatives? And if so, what's been done to help improve and get to those?
Yeah. It's a good question. I think the last time I looked at the data, we skew towards about 75% of our staff identifying as female, and but when we look at our mental health and wellbeing training or accessing our staff psychologists, even though we've got a much smaller percentage of staff identifying as male, that we don't see anywhere close to the number we should expect of those. So for us, that is a definite group. And that's worrying for us, because actually then when we look at our first line managers, we actually skew towards identifying as male within that group. So even if we're just thinking in terms of looking after their teams and looking after those that they manage, as well as looking after themselves, we know from the mental health and wellbeing side, that's a particular group. Another group are our night shift workers. We have groups of staff, particularly with our facilities groups, that pretty much work nights, and they are very difficult to often access. A lot of the people who do a lot of the work around the training, occupational health and everything, their hours don't tie in. So we need to be really flexible in the way that we work and access and provide that access for that group of staff. And also digitally, our staff that are not digitally enabled for a variety of different reasons, whether because of their work, they're not sitting in front of a computer for a lot of the day, or they don't have very easy access, or perhaps that isn't something that is a particular strength or skill. And when you've got, we've got 4 acute sites, and we have staff on over 100 community sites. When you're relying on communication of staff wellbeing, activities, events, support, and that being very digitally driven, that is a challenge. Some of the things we're doing, What we're great at doing is piloting things. So we've got a really well embedded group of staff psychologists. They're embedded in our directorates and they're great at actually gathering a lot of information. We also have a growing group of wellbeing champions, which started at pace during the pandemic. We've gone from sort of 45 in the first tranche, we're at about 250, and we have a lofty aim for 1 per team. And we see these as really our way of getting from a very small core health and wellbeing team to every team across our large trust, so that we can ensure that information, up-to-date signposting gets there, that they're there to support managers with wellbeing conversations, and that they can also pull back those themes and trends of things that are working well and places where we could do better. A really exciting pilot that we are going to be working with somebody on. We're going to be working during the summer to set up a pilot specifically for our male staff and mental health, is with a person who has lived experience of mental health illness and is a stand-up comedian. We had a few tasters with him and to see how it would go down. And he uses the skills of stand-up as a way of getting people to be able to talk about mental health, but also to be able to express and communicate mental health difficulties that they may be having. What we found in those 2 tasters that we just tried out as a promotion was that we got a 60% male audience. So we knew we were tapping into something there. So I think the great thing is we're happy to pilot things. We'll base them on evidence, and if they work, then we'll go to our charity and ask them to support us for us to broaden it further.
Brilliant. And presumably if they work, you know, other trusts can take inspiration from those and share some of those ideas. Emma, I was just wondering, you know, from your point of view, whether there are groups of people that are difficult to reach. Joan was mentioning they're particularly night shift workers for obvious reasons. You know, what do you find? Do you find there's some staff members that are difficult to get to?
Yeah, so night shift workers are difficult, but notoriously senior doctors are as well, because they don't want to admit they've got a problem. So that can be a real difficulty. And one of the things we did to support that is that we set up peer support groups with people from every sort of specialism within the critical care unit, so that we could support different people, so that they could go to their own peers rather than having to tell everybody that they had a problem. And that's where the coloured counters also came in useful there. But it can be really difficult to reach people, because people are reluctant to admit that things aren't going well. And then particularly, you know, if you feel you need to take time off, then everybody knows you've got to take time off. You can't sort of sneak out the back door and take time off. So I think people do feel very conscious of that. But I think opening up the conversation about it has really helped. Yeah. And because if everybody's talking about it, then those that are a bit more reluctant to come forward and say, yes, I'm not feeling so good either, they're much more able to do that if the conversation is more open. So I think that's definitely helped.
Absolutely. Aileen, do you see any improvement in staff morale when they're involved perhaps in leading on innovation in their workplace?
Yeah, actually, that's a really great question, because yes, we do. And I guess it's not surprising, because to be at the cutting edge of something is often exciting. It's, you know, it involves work, but it's often exciting. And, you know, as I've said before, we have to have evidence that it improves patient outcomes. And I think probably for everybody that's in this room today with us, that's the most important thing, that actually we're all working within health and care because we want to improve the patients that we're in, and you know, the outcomes for the patients and their families. We want them to have a better life, better health. And if what we're bringing actually enables that, then it's just a knock-on effect. We've been out to our stakeholders recently and asked them whether they enjoyed working with us. We asked them a number of questions, but one of them, which we thought was just a kind of we'll just throw it in question, was actually, you know, responded to. But 90% of them said, yes, we enjoy working with you. And we know it's a tall ask to say to people to do this on top of your day job, you know, bring something new into your organization. So yes, there's definitely evidence to show if you're at, you know, implementing something new that works, that improves lives, both yours as a staff member and as a patient and their family, then yes, there's evidence that we can help hopefully retain those staff in their workplace.
Andrew, we've talked a little bit about what help is available. What help, in your opinion, should be available?
So, I mean, we're calling at the British Medical Association for the introduction of a national wellbeing service for NHS staff, including in primary care, because there are some very good examples, as we've heard, in big hospital trusts. There are some very poor examples in big hospital trusts, sadly, but there's very little out there in primary care, and there are huge numbers of nurses, doctors, and other health professionals and admin staff who work in primary care who don't really have access to much at all. So we're calling for a coordinated national approach to try and protect the workforce so that they can in turn protect patients.
Absolutely. Joan, final question of the day to you, slightly playful, but if you had a magic wand and you could instantly do one thing, what would it be?
We've started, but we would love for all of our managers, as mandated from the very beginning, to know what's available across our trust. We've got a huge amount available in terms of signposting and support for our staff, but really sometimes they are the first point of contact or the first person that might pick up that there's something not quite right, and that would be the first thing. And the second, and if I'm allowed one more, I just would like to
have one more in your magic wand.
to our senior leaders attending this with them, so that the organizational change that my learned colleagues have spoken about has actually got a chance of happening. Because the first bit of feedback I always get is, it would be great, but why doesn't my manager come along to this?
Good. Well, those are very good kind of thoughts to end us on. Thank you very much for that. I mean, thank you to all of you, to Aileen, to Emma, Joan and Andrew. This is such an important conversation, and you know, it means an awful lot to the organisers of this conference today, and to me, that you come along and give your time to share what's going on and to share your opinions. And please take part in another one of these for us, because that half hour certainly whizzes by, and you've made a fantastic contribution. So very, very nice to see you today. I'd also like to thank you, to everybody who joined us in our audience today and gave up your time to be here. And a massive thank you to our partners. We simply couldn't hold these events without their expert knowledge. I look forward to seeing many of you at our next event, which is Digital Health. That's taking place on July the 27th. So please share the word with your colleagues. They'd be very welcome to come along too. Quick reminder, today's event was CPD certified, with 1 CPD point for every hour of live content you watch. Your CPD certificate will be with you, I'm told, 24 hours after the end of this conference. So from me and everybody at NHE 365, do enjoy the rest of the day. I'll see you soon. Bye for now.